To study the issues in more detail, I'm going to turn to the Medicare example. As I mentioned, this example is based on Amy Finkelstein's 2007 paper, but we're going to abstract away from many important details in her original paper and focus on the identification strategy. Specifically, suppose we're only interested in the impact of Medicare on per capita healthcare expenditure, denoted to be YST, where S indexes US states and T indexes time periods. I'm going to focus on the situation where we have only two time periods and at T equals to 0 to denote the base period before the introduction of Medicare, and T equals to 1 to denote the period after. Because many things change over time, simply comparing expenditures at time equals to 1 to those at time equals to 0 might not give a reliable estimate of the effect of Medicare. Instead, Amy took advantage of the fact that states differ in their fraction of the elderly that were insured prior to Medicare. Specifically, she focused on the share of the elderly that had hospital insurance provided by Blue Cross. And that's because many private insurance plans before 1965 only had limited coverage, but the Blue Cross plan was the most comparable to Medicare and would become redundant once the individual receives Medicare. In table 1 of her paper, we see quite a lot of variation across states in terms of the private insurance coverage, ranging from high coverage in a New England state where only 49% of the elderly did not have Blue Cross insurance, to low coverage in a Pacific state where as high as 87% of the elderly did not have private insurance prior to Medicare. So this means Medicare would have a relatively small effect on the rate of insurance coverage for a New England state relative to a Pacific state. More formally, I'm going to use XST to denote the fraction of the elderly with health insurance in a given state S at time t. And XS0 is the fraction of the elderly with private insurance prior to Medicare. And due to the universal coverage introduced by Medicare, XS1 is going to equals to 1 for all states. With these notations, we can write down a linear panel model of healthcare expenditures, where YST is assumed to be composed of state fixed effect alpha S, time effect delta T, beta times the insurance coverage rate XST, and an error term that's assumed to be unrelated to the other terms. Here, the parameter beta is of the greatest interest as it measures the causal effect of insurance coverage on healthcare expenditure. Specifically, it measures the effect on per capita health expenditure of going zero coverage to full coverage. Now, because X equals to 1 for T equals to 1 for all states, we can rewrite this linear panel model in a form that's closer to the heuristic model. Recall the heuristic model includes the interaction between the event variable and the exposure variable. Here, the exposure variable is 1 minus x0, which measures the increase in insurance coverage due to Medicare. The event variable is an indicator for t equals to 1, which is the introduction of Medicare. Here, the trick for rewriting is just to redefine the state fixed effects by including the initial impact of insurance coverage on healthcare expenditure. More practically, we can estimate the unknown coefficient beta by regressing the healthcare expenditure on state indicators, time indicator, and interaction between the fraction that's previously uninsured and the time indicator. This is a two-way fixed effects estimator, and let's call it beta hat from now on. Beta hat has many appealing properties, which might be why it's used broadly in applied research. When the exposure model is correct, Beta hat is an unbiased estimator for beta. If further, the error terms are homoscedastic and are not clustered or serially correlated, then beta hat is also efficient. Intuitively, how the two-wave effects estimation works is that under the exposure model, we can learn about the coefficient beta by looking at whether, following the introduction of Medicare, healthcare expenditure diverge between states with different levels of private insurance before Medicare. If they do, then because different states are affected equally by the time effect represented by delta t, this divergence must be due to Medicare, which is beta times 1 minus x as 0. From there, we can back out the per unit effect of insurance on expenditure, which is beta. So this is saying, for a given change in the fraction insured has the same effect on per capita health expenditure in every state as. And the effect of Medicare on healthcare expenditure differs across states only because of their different effect on insurance rate. But it seems plausible that healthcare expenditure will respond differently to changes in insurance in different states as well. And that's what we will turn to next to discuss the implication of relaxing the assumption of homogeneous coefficients.